Welcome to Topic 5, Part 1, Disorders of the Vasculature. I'm just going to go over a few things with you. Starting just to remind you to review your normal heart anatomy. You should know what all those terms mean and how blood flows through the heart. The normal EKG, you should know what each of these waves represent. And you should know how the wave of depolarization spreads from the SA node throughout the heart. Here's a chance for you to trace the flow of blood through the heart and circulation. Make sure you can put these terms in order. And then you'll also want to review the cardiac cycle. Make sure you understand what is happening during ventricular systole, during ventricular diastole. Know when the heart valves open and close, and what conditions, systole or diastole, that cause those changes. Okay, you'll also want to review cardiac output and the factors that affect cardiac output, heart rate and stroke volume. So if we look at stroke volume is going to be determined by three factors: preload, contractility, and afterload. Preload is determined by the amount of stretch on the ventricular muscle, which is going to be determined by the end diastolic volume, or how much filling occurs. So in a normal heart, this would be in the optimal range. Blood is returned to the heart, and the greater the return of blood, the greater the stroke volume, and thus the cardiac output. If the heart becomes overfilled, which can occur with heart failure, if the heart is not strong enough to pump all of that blood out, then much of that blood remains and the end diastolic volume builds up. In which case, then the heart is overstretched. There's less overlap between actin and myosin, and the heart is weak, and we see a decrease in stroke volume. But the normal curve is with increasing end diastolic volume, we see increasing force of contraction. The amount of that end diastolic volume is going to be determined by the venous return, which is going to be dependent on the blood volume, the filling time, which would be determined by the heart rate, and how much tone there is in the venous system. Stroke volume is also going to be determined by the cardiac contractility, and this is the ability of the heart to change the force of contraction, to increase the force of contraction without changing the preload. So in other words, at the same end diastolic volume or preload, we have an increase in the force of contraction. This is also referred to as inotropy. And the force of contraction can be increased by the sympathetic autonomic nervous system, epinephrine, calcium, and it can be like extracellular calcium, and it can be decreased by myocardial infarction because we have less contractile tissue, acidosis, and hypocalcemia. And then afterload also affects stroke volume. And the afterload is the pressure or tension that the heart must generate in order to open the aortic valve and move blood into the aorta. So in this case, an increase in afterload will decrease stroke volume. And afterload can be increased by an increase in blood pressure, so in like hypertension, increased viscosity of the blood or thickness of the blood, like in polycythemia, and also with aortic stenosis or narrowing of that aortic valve. That can all lead to an increase in afterload. Okay, that was it for the review. Now we're going to look at disorders of the vasculature, starting with disorders of the arteries. So just a quick review: a thrombus is a blood clot that forms within a blood vessel or heart chamber, and it stays there. We can describe this thrombus as being in the arterial system, and those tend to form in areas that produce turbulent blood flow and platelet adherence. So this includes like atherosclerosis. The way it damages the blood vessel, it produces more turbulence, as well as aneurysms. Venous thrombi, on the other hand, tend to form when blood flow is more sluggish. For instance, with bed rest and mobility, with myocardial infarction, because the heart is not pumping the blood through the circulation very well, or if we have a hyperactivity of blood coagulation, or vascular trauma. Now, an embolus can be a thromboembolus, meaning a thrombus that cut loose and becomes a thromboembolus. But an embolus could also be a mass created by an air bubble, fat, bacteria, cancer cells. Anyway, a pulmonary embolus is going to originate on the venous side, and most of these originate in the deep veins of the legs or within the right heart. So the ones in the deep veins of the leg, those are called deep vein thrombosis. And if you think about it, if a blood clot forms in a vein, as you go back to the heart, veins get bigger and bigger, so it doesn't get caught in the veins because they're increasing size, diameter of size. So they go back to the heart, it goes to the heart, and then the right heart pumps it where? To the lungs. And as we go through the lungs, the blood vessels are getting smaller and smaller until that embolus gets trapped. Systemic emboli usually originate in the left heart. For instance, after a myocardial infarction, so the heart's not pumping very efficiently, so blood kind of pools a little bit with like atrial fibrillation, congestive heart failure, and endocarditis. Okay, now looking at some of the diseases of the arteries. Arterial sclerosis is when we have abnormal thickening and hardening of the vessel walls. So we get smooth muscle cells to proliferate and collagen fibers, and they migrate into the intima, in the intima layer, and that's going to cause a narrowing of those arteries. Atherosclerosis is a type of arterial sclerosis, but it is differentiated by accumulation of lipid-laden macrophages in the arterial wall. And this is going to be common when we have high amounts of LDL. So you might want to just quickly review your lipoproteins as well as lipid transport, and then take a look at hyperlipidemia. Now I want to talk about the progression of atherosclerosis. So it starts with endothelial injury, and that is caused by high blood lipids, smoking, high blood pressure, diabetes mellitus, or various immune mechanisms, and turbulent blood flow. And essentially these things damage the endothelium, and that causes an inflammatory response, and that's going to cause white blood cells, monocytes, as well as platelets to migrate to the area in response to chemical mediators released from the damaged tissue. Okay, so the inflammatory process begins. The inflammatory cells are drawn to the area, and we have the development of the first atherosclerotic lesions. Then we start getting lipid accumulation and proliferation of the smooth muscle cells. So macrophages, so remember those monocytes that come into the tissue, they become macrophages, and they release enzymes that can act to oxidize LDL in the area. The macrophages then engulf the LDL, and they become foam cells, and they penetrate into the intima of the blood vessels. These macrophages also produce growth factors that stimulate the smooth muscle cells to grow and divide, and as well as production of more collagen fibers. So that causes the development of a fibrous plaque. So we have kind of aggregation of smooth muscle cells, macrophages, collagen, and elastic fibers kind of form the plaque over this pool of lipid. And you can see how, as this builds up, this is going to cause narrowing of the artery. If this was in the coronary arteries, this could lead to angina when there's increased demand of the tissue for oxygen, such as with exercise. Now, if the plaque could become complicated, so if the plaque thins and ruptures, platelets aggregate at the lesion, and then we get formation of the thrombus. And this can lead to, if in the coronary arteries, unstable angina or myocardial infarction. Okay, so what are the consequences of atherosclerosis? Well, it depends on which blood vessels are affected. As I was talking about in the coronary arteries, this can lead to coronary artery disease, So of the arteries that supply the heart muscle with their nutritive blood flow, if atherosclerosis develops in them, that can lead to angina and or myocardial infarction. If it occurs in the carotid arteries or in the cerebral vessels within the brain, this is going to be called cerebrovascular disease, and this can cause transient ischemic attacks or strokes. And then atherosclerosis can also occur in peripheral arteries such as the aorta, which could cause aneurysms, the iliac, thoracic, or femoral arteries, leading to peripheral arterial disease. Okay, so let's look at peripheral arterial disease. I already mentioned the sites. This is most common in men in their 60s and 70s, and cigarette smoking and diabetes mellitus are huge risk factors. A partial occlusion can impair muscle and sensory activity, but total occlusions can lead to a loss of blood flow, which can then lead to necrosis, ulcers, gangrene, and eventual amputations. So what are the signs and symptoms? We can have fatigue and weakness in the legs. A big classic sign is this intermittent claudication, which is leg pain associated with exercise. So this is kind of like angina in the legs, okay? We can also have sensory impairment, so the paresthesias, that pins and needles, burning, numbness. The skin tends to be shiny and hairless because there's not as much oxygen to supply those tissues. And then another classic sign is that the appearance of the skin of the feet and legs changes with gravity. So we have pallor and cyanosis when the legs are elevated, but they tend to be red when dangling, when we have gravity aiding blood flow to that area. Raynaud phenomenon and Raynaud's disease. This is not atherosclerosis, but this is where we get pallor and cyanosis of the digits, particularly of the fingers of the hands. And this is due to a vasoplastic response. So the smooth muscle cells of the arterioles feeding those fingers contract and severely constrict blood flow to those tissues. There are two types. The Raynaud's disease, which is the primary disease, it's idiopathic, don't know what it's caused. But it seems more common in young adult women, and it's precipitated by exposure to cold. One of my friends has it so bad she has to wear little gloves when she's in the grocery store going through the frozen food aisle. Raynaud's phenomenon is the disorder that's secondary to another disease, such as secondary to lupus or atherosclerosis or pulmonary hypertension. Okay, aneurysms. Aneurysm is where we have a local dilation in the wall of a vessel, and this is usually caused by weakening of the arterial wall. This could be congenital, but it also can be precipitated by atherosclerosis. There are some risks of clot formation due to these aneurysms, rupture of the aneurysms, and that could lead to hemorrhage. A true aneurysm is bounded by a complete blood vessel, where a false aneurysm, we have a tear in the inner wall, and we get the formation of an extravascular hematoma. Okay, and then as I mentioned, etiology, arteriosclerosis or atherosclerosis, trauma can also cause this. High blood pressure, syphilis, or other infection can lead to the formation of these aneurysms. This just outlines some of the different types. The one I wanted to point out, though, was dissecting aneurysm. This is a type of false aneurysm in which there's a tear in the intima, that's that inner lining of the blood vessel, and blood flows between the layers and dissects those layers of the blood vessel wall. Aortic aneurysms are the most common type of aneurysm, accounting for about 80% of aneurysms. They're more common in males than females. They can be asymptomatic until they're large or rupture. Complications can include rupture and hemorrhage, obstruction of branch vessels, impingement on neighboring structures if it's really big, emboli, thromboses, And then aortic dissection. So once again, that dissection where the blood dissects the layers of the blood vessel wall. Hypertension is a big risk factor for aortic dissection. Do take some time to answer these questions. And now we're going to move on to disorders of hypertension. So first, let's talk a little bit about the blood pressure. So remember, the cardiovascular system is a closed system under pressure. So the pressure is greatest near the pump. So the greatest blood pressure is in the aorta, and then this declines as we go all the way back to the heart, with it being lowest in the vena cava. The systolic blood pressure is measured during ventricular systole. The diastolic blood pressure is measured during ventricular diastole. And the pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. And you can see the pulse pressure is great in the aorta, and then that evens out as we reach the small blood vessels. So let's look at the mean arterial pressure. So the mean arterial pressure, we could calculate it as 1/3 the pulse pressure plus the diastolic blood pressure. Note we weight the diastolic pressure more because the heart spends more time in diastole than it does in systole. We can also look at the mean arterial pressure as being the product of the cardiac output times the total peripheral resistance. So what this tells us is that changes with cardiac output or changes with total peripheral resistance are going to lead to changes in mean arterial pressure. In general, changes in cardiac output are going to be reflected as changes in the systolic blood pressure, and changes in the total peripheral resistance are going to be reflected as changes in the diastolic blood pressure. So let's look at those factors that affect cardiac output and total peripheral resistance. Okay. So first, the cardiac output. So the cardiac output is equal to the product of the heart rate times the stroke volume. The heart rate is going to be affected by the autonomic nervous system. So the sympathetic branch increases heart rate, parasympathetic decreases heart rate, as well as hormones such as epinephrine, which is going to increase heart rate. The stroke volume, as we talked about earlier, is going to be affected by the preload, the contractility, and negatively affected by the afterload. So an increase in preload would lead to an increase in stroke volume. So the things that affect preload is the venous return, the amount of blood returning to the heart. And that venous return is going to be dependent upon the venous tone, how much are the veins constricted by smooth muscle cell contraction. The sympathetic branch of the autonomic nervous system stimulates the smooth muscles of the veins, and that causes some contraction, and that's going to increase the pressure in those veins to help promote blood return to the heart. Okay, and this is aided by those one-way valves. So when we squeeze on the vein, the blood goes back towards the heart. Venous return is also going to be dependent upon filling time, and filling time is dependent upon the heart rate. So we could say the greater the heart rate, the less time we have for filling, and the lower the venous return. Now, however, in exercise, we still see an increase in venous return because we have other factors going on. So even with an increase in heart rate, we are also going to have an increase in venous tone, and we're also going to have the skeletal muscle pump and the respiratory pump, and that's all going to aid in venous return. Additionally, with exercise, we're going to see an increase in contractility. So that's going to increase the efficiency of the heart to help increase stroke volume. Okay, but going back to venous return here, blood volume is the other factor that's going to affect venous return. So if we were hemorrhaging and we lost a lot of blood, obviously we couldn't return a lot of blood to the heart. We would see a decrease in preload, or EDV, a decrease in stroke volume, and a decrease in cardiac output, and thus a decrease in blood pressure. Going back to this filling time again. So I said with exercise, we have other things that are happening that help to maintain, in fact, actually increase cardiac output at least 5 times. With exercise, we can do that. But if we have, say, ventricular tachycardia, where we have a really rapid heart rate due to an arrhythmia rather than exercise, That's going to lead to a decrease in venous return, a decrease in preload, a decrease in stroke volume, a decrease in cardiac output, and thus a decrease in the mean arterial pressure. Okay, now going to the contractility. Contractility, remember that's that increase in force of contraction independent of EDV. The sympathetic branch of the autonomic nervous system innervates the heart, and that's going to increase contractility. So do the hormones such as epinephrine increase contractility. That would increase stroke volume and increase cardiac output. And then we talked about some other things that could negatively affect contractility, such as with a myocardial infarction, we don't have enough cardiac myocytes to adequately contract the heart, and that would cause a decrease in stroke volume and cardiac output. And then afterload. Afterload is the one factor that negatively affects stroke volume. If we have an increase in afterload, such as with hypertension, polycythemia, aortic stenosis, that's going to lead to a decrease in stroke volume, and that will lead to a decrease in cardiac output. Okay, so now let's look at the other end of that equation, the total peripheral resistance. So then the factors that affect that. There are three things. Blood viscosity, that's how thick or viscous the blood is. If we have increased viscosity, that's going to lead to increased resistance of blood flow. And that would increase the mean arterial pressure. Now normally this is pretty much a constant thing, but it is increased with polycythemia, which we just talked about in topic 4. And would be decreased in the opposite with anemia. So if the blood is thick like molasses, that's going to be increased viscosity. It's going to be an increased total peripheral resistance, and that would lead to an increase in blood pressure. The next factor is the total blood vessel length. And what we're saying here is the longer the total vessel length in series, the greater the resistance. For instance, if we look at the difference of the resistance between the systemic circulation, which has a whole bunch of blood vessels in series, because we have to go from the heart all the way to the toes, to the fingers, throughout the body, versus the total blood vessel length in the pulmonary system. Going from the heart to the lungs is not very far. So if you recall, the blood pressure in the pulmonary system is about 1/5 that within the systemic circulation, and this is because we have such a decrease, that one of the factors is we have such a lower total blood vessel length. This also accounts for the difference in blood pressure between children and adults, because children are smaller than adults. However, total blood vessel length is really a constant, okay, for the most part. So it's not, at least on a moment-to-moment basis, that's not going to change. So the most important factor on a moment-to-moment basis is the arterial diameter, because the resistance varies inversely to the 4th power of the vessel radius. Okay, so small changes in blood vessel radius are going to dramatically increase the peripheral resistance, and thus will increase the blood pressure. Okay, so this factor can change on a moment-to-moment basis, and this diameter can be increased by, the smooth muscle cells can contract in response to sympathetic stimulation. Contraction of those smooth muscle cells leads to vasoconstriction, and that will lead to an increase in total peripheral resistance and thus an increase in blood pressure. There will be anything that can lead to vasodilation, such as histamine. So say with anaphylactic shock, the massive release of histamine causes widespread vasodilation, and that's going to lead to a decrease in total peripheral resistance and a decrease in mean arterial pressure. Okay, so those are the things that control total peripheral resistance. Let's look at the things that regulate blood pressure in the short term. So the short term is through neural regulation via the baroreceptor reflex. We looked at a lot of the things that the sympathetic autonomic nervous system affects. And vagal activity, that would be parasympathetic. We have parasympathetic stimulation to the SA node that would decrease the heart rate. The sympathetic nervous system stimulates both the SA node to increase heart rate, the ventricles to increase contractility, and the veins to increase venous return, which would help to increase preload. And also the sympathetic nervous system would stimulate the arterioles to increase total peripheral resistance. All those things would act to raise blood pressure via the sympathetic nervous system. The vagal response, once again, which would be parasympathetic stimulation, that's only going to affect the heart rate, and that will act to decrease heart rate. We also have some other chemoreceptors that sense hypoxia or decreased O2 or increased CO2, and this can stimulate vasoconstriction and an increase in total peripheral resistance. We also have hormonal regulation by epinephrine, which would increase heart rate, contractility, and total peripheral resistance, as well as angiotensin II. On the long-term regulation, we'll see that blood pressure is regulated by the kidneys through primarily the renin-angiotensin-aldosterone system. So let's look at that. The first mechanism actually is the direct renal method. So this is fairly straightforward. If we have an increased blood pressure, that's going to lead to an increased glomerular filtration rate. So then you're going to pee out more, and that would lead to a decreased blood volume, and thus that would cause a decreased blood pressure. The next factor is through thirst and ADH. So if we were to have a decreased blood volume and thus blood pressure, that's going to stimulate thirst, so that would act to you take more fluid in to increase blood volume, and antidiuretic hormone, which would act to increase water reabsorption from the kidney tubules, and that's going to act to increase blood volume. Okay. And then we have the renin-angiotensin-aldosterone system. So let's walk through this. So if we have a decrease in blood pressure, this is sensed by the juxtaglomerular or JG cells of the kidney. They then, in response to this, secrete renin. Let me also mention, if the blood pressure is really low, the sympathetic nervous system will stimulate those cells also to release renin. So we kind of have a dual mechanism. Renin is an enzyme that gets released into the blood, and it acts on angiotensinogen, which is found in the blood, and converts it to angiotensin 1. Angiotensin 1 goes through the bloodstream and comes into contact with angiotensin converting enzyme within the pulmonary capillaries of the lung. Angiotensin ACE, or we call it angiotensin converting enzyme, converts angiotensin 1 into angiotensin 2. Angiotensin 2 then acts on the adrenal cortex to release aldosterone. And aldosterone acts in the kidneys to increase sodium reabsorption. And as long as ADH is present, water will follow that sodium, and we'll see an increase in vascular volume and an increase in blood pressure. Okay, and then also angiotensin 2 will also act on the arterioles to increase vasoconstriction of those arterioles, which will increase TPR, total peripheral resistance, which will increase blood pressure. Okay, and then finally the last one kind of has the opposite effect of the renin-angiotensin-aldosterone system. Atrial natriuretic peptide. This is released by the atria of the heart. So when there is excess blood volume within the atria gets stretched, and that causes those cells to release ANP. ANP acts in the kidneys to cause sodium excretion. Water follows sodium, and you pee that out. That's going to lead to a decreased blood volume, which would act to decrease blood pressure. ANP also acts on the arterioles in the opposite manner as angiotensin 2. It causes vasodilation. That would lead to a decrease in total peripheral resistance and a decrease in blood pressure. Okay, let's talk about hypertension. Hypertension is when we have a consistent elevation of the systemic arterial blood pressure. It's very common as we get older. We see it in at least 1 of 3 adults. It increases with age, so 60% in people older than 65. So it gets really high. This shows just normal blood pressure values. You might want to write them on your card that you can use for your exam. Types of hypertension, we have 2 types, primary or essential hypertension. This is the most common. And this is hypertension that's not associated with any other disease. And then secondary is caused by another disease process. The problem with hypertension is that this high blood pressure is going to lead to damage to the arterial walls. This can cause remodeling and hypertrophy, hyperplasia of the vascular smooth muscle that leads to arteriosclerosis, where the arteries become hard and thick. It narrows the lumen. That causes the heart to have to work harder. That can lead to congestive heart failure. It can also lead to atherosclerosis. It can lead to myocardial infarction, stroke, and renal failure are all negative consequences of hypertension. So let's look at primary. Primary or essential hypertension makes up about 90 to 95% of all causes of hypertension. We don't really know the cause, but there are some risk factors, constitutional things that we can't change, and lifestyle risk factors, things that we can potentially change that put you at increased risk for hypertension. But as I mentioned, just increasing age is a really big factor. As we get older, our blood pressure tends to increase. Okay, this slide looks at some of the common treatments for essential hypertension. Lifestyle changes, certainly a reduction in sodium, but just losing weight, exercising, and not drinking too much can help lower your blood pressure. And then many people are going to need pharmacological interventions in order to lower blood pressure. And this is important to keep blood pressure low, remember, because of all those negative consequences occur if we do not take care of our blood pressure. So ACE inhibitors, they inhibit that enzyme that converts angiotensin 1 to angiotensin 2, and that's going to help to lower the total peripheral resistance because we'll have less angiotensin 2. It's also going to lead to decreased aldosterone levels, so that will lower our blood volume. Beta blockers act to decrease heart rate, cardiac output, and decrease the renin release, which is going to promote aldosterone and angiotensin 2. Calcium channel blockers going to inhibit calcium movement into the vascular smooth muscle. That can cause vasodilation and decrease total fluid. And then finally diuretics, which lead to increased sodium and water excretion, which is going to lead to decreased blood volume and thus decreased blood pressure. Secondary hypertension, on the other hand, is caused by a disease process that raises either peripheral vascular resistance, TPR, or cardiac output, or both. By some systemic disease process. Sorry, I'm being repetitive there. Anyway, secondary hypertension only makes up about 5 to 10% of the hypertension causes. Let's see, and these are divided into renal causes. So we can have renal vascular hypertension. This is the most common cause of secondary hypertension. So this is caused by reduced renal blood flow through the kidneys, which is going to lead to increased release of renin and activation of the renin-angiotensin aldosterone system. This is usually caused by atherosclerotic lesions or stenosis of the renal artery. So we have decreased blood flow through the renal artery, and that is sensed by the kidneys. They think, oh, that seems bad because we're not getting enough blood flow, so we must need to increase blood volume, so they cause the release of renin. Chronic pyelonephritis is a kidney disease, polycystic disease, other kidney diseases, end-stage kidney disease such as caused by diabetes mellitus. These are all renal causes of secondary hypertension. We can have some endocrine causes such as Cushing's syndrome, where we have too much release of cortisol and also a little bit of aldosterone. That's going to increase blood volume and blood pressure. Con disease, which is due to hypersecretion of aldosterone. And then phaeochromocytoma, which is when we have a catecholamine secreting tumor. So we secrete too much epinephrine. The coarctation of the aorta, this is a congenital condition in which the lumen of the aorta is narrowed. And then last but not least, oral contraceptive drugs can also lead to secondary hypertension. Hypertension is often referred to as the silent killer because it occurs asymptomatically until damage is done, so you don't necessarily feel the development of hypertension. That's why it's so important to get regular blood pressure checks, because that's the only way we can tell before there is damage that you have high blood pressure. There can be some initial signs such as headache, but the initial signs are pretty vague and nonspecific. But over time, chronic hypertension leads to damage to tissues and organs. It can lead to hypertrophy of the heart, congestive heart failure, coronary artery disease. In the brain, it can lead to transient ischemic attack and stroke. In the kidneys, it can cause nephrosclerosis and chronic renal failure. In fact, hypertension is the second most common cause of kidney failure. Diabetes mellitus is the first. In the eyes, it can cause retinopathy and can also lead to that vascular peripheral arterial disease. Hypertensive crisis is a medical emergency where we have a marked increase in blood pressure that leads to progressive or impending target organ damage. This is defined as a systolic blood pressure of greater than 180 and or with a diastolic blood pressure of greater than 120. So it can cause changes in mental status, it can cause intracranial hemorrhages, it causes retinopathy, dissection of the aorta, cardiac ischemia, heart, or renal failure. This is more common in secondary hypertension to see this marked elevation of blood pressure. And this requires medical treatment with continuous blood pressure monitoring, having to be careful not to suddenly decrease blood pressure, which could lead to tissue hypoperfusion. Okay, gestation hypertension. This is defined as hypertension occurring after 20 weeks gestation. It may resolve within 2 weeks of termination of pregnancy, and it may progress to preeclampsia. Preeclampsia is specific to pregnancy and is defined as an elevation of blood pressure of systolic greater than 140 or diastolic greater than 90 and protein in the urine of greater than 300 milligrams in 24 hours. Once again, this is defined as developing after 20 weeks of gestation. And then, eclampsia is when then we see the occurrence of seizures in those women that have preeclampsia. This is it puts both the mother and baby at high risk. It can lead to endothelial injury, which can lead to DIC, thrombocytopenia, cerebral hemorrhage, liver failure, and kidney failure. Okay, we'll look real quickly at disorders of veins. Varicose veins, this is where we have irregular, dilated areas of the superficial or deep veins, which is more common, of the leg. They can be caused by a defect or weakness in the vein walls or valves. This could be partly genetic, can also be caused by trauma. Factors that increase pressure in the leg veins include standing long period of time, crossing legs, and pregnancy. I know I developed some of these very gross veins, as my mother calls them, when I was standing long periods of time teaching back-to-back 3-hour classes in the summer while I was pretty far along in pregnancy with my second child. Some signs and symptoms, it can lead, obviously, we know what they look like, irregular bulging veins, but it can also cause edema, fatigue, and aching if this edema interferes with arterial blood flow and slowed wound healing. Venous thrombosis is when we have the presence of a thrombus in a vein and then the associated inflammatory response. The Virchow triad describes the three factors that lead to an increase in thrombus development in the veins. So we can have stasis of blood flow, and this can be due to bed rest, immobility, spinal cord injury, MI, heart failure, shock, obstruction of the veins. Coupled with increased blood coagulability, this can be genetic, stress, trauma, pregnancy, childbirth, cancer, oral contraceptive hormone replacement, or dehydration. And then vessel wall injury. This can be caused by surgery, trauma, infection, or venous catheters. I put this picture of this guy in this airplane. Immobility or stasis of blood flow here. Long airplane flights is important to exercise those calf muscles to try and prevent stasis of blood flow in those veins of the legs. So one of the risks of venous thrombosis is a pulmonary embolus. So if that thrombosis cuts loose, remember it will travel back through larger and larger veins till it gets to the heart, and then the heart will pump that thromboembolus to the lungs, where it can block pulmonary arteries. There are some preventative measures that can help prevent the development of deep vein thrombosis. Ambulation after childbirth or surgeries, exercising legs, like I mentioned on the plane flights, supportive stockings or TED hose, or some type of pneumatic compression device. They do these a lot after various surgeries. All right, well, that's all for now. We'll catch you for part 2 of topic 5.